All right, so we'll get started. I think there are a bunch of people who are getting food, so they might not be as good at taking care of cardiogenic shock by the time they walk in. First years are not here yet. You're here. Okay. So a lot of this is what a few of the other fellows, the senior fellows who've been around have seen. So I think Fahim said that I should stop at each slide and ask him what the next slide is going to be because they know my presentation. Oh, there you go. So these are the patient profiles you guys will see. Come in the middle of the night. Of course, everything happens in the middle of the night. That's why you guys are on call. Getting 100 phone calls, but like everything in medicine that you learn from internship to up, when you certain things are important for you to pause and make sure you're expert enough because time is sensitive. High lactate, right? High creatinine, high BNP, non-ischemic, ischemic, whatever it is. This is multi-organ dysfunction that you're seeing with cardiogenic shock. So this is just an example of what you see. But when we talk about cardiogenic shock, it's appropriately phrased as a momentary pause in the act of death. I mean, the people are actively dying, but you're having that pause to see if you can abort death because shock is fatal. The true definition physiologically when you say shock, any shock is inadequate organ perfusion, right? And each organ fascinatingly has different reserve. So whether you find organ dysfunction in one organ versus the other, I think is a different discussion, but you have to keep in mind that when people are in shock, hypoperfusion can range from showing renal failure to liver failure or not, and that means that you might find liver failure, might not find liver failure. Hypotension is a component of any shock, and the trial definitions have used a systolic blood pressure of less than 90 or a MAP less than 60 or a decrease in the systolic blood pressure more than 40 millimeters mercury from the patient's baseline pressure. The 90 millimeters mercury is an artificial number, right? We all know that. I have seen people in hypoperfused state with a blood pressure of 110 over 60. So end organ function is a reflection of blood flow to the organ. Blood pressure is a reflection of flow plus the resistance of the vessel. So you can have high resistance, maintain good blood pressure, but have a clamped down state and have hypoperfusion in organs. So it's important in the clinical world not to walk away just because your trial definition of systolic blood pressure was not met. Right? So we've seen, you see this enough, you'll see heart failure enough, you'll recognize that. And when you talk about shock and cardiogenic shock, it's definitely relevant and important for you to think about the physiology that your cardiac output is a central focus. Your effective cardiac output is decreased, and that's why it's cardiogenic shock. You meet the definition of shock that we talked about, but the source should be cardiac to an extent, a contributor. Right? You can always have mixed shock. The blood pressure, as we talked about, is a reflection of output and resistance. So if somebody's output is low, it's technically cardiogenic shock, but if the resistance is high and the output is low, then you're not going to go start flogging the heart. So the physiology of shock is very important to optimize. Same thing with preload. You can be in technically cardiogenic shock with an index of 1.6 if your CVP is -1. But those are not the people you're going to put them on dobutamine and milrinone, right? So you need to know the CVP, and that's where hemodynamic assessment is important. And hopefully all the interventional blasts who graduate out of this program will dream about me in a STEMI and put in a Swan-Ganz catheter. I urge you guys, don't listen to Kleiman. So preload contractility, afterload contribute to cardiac hemodynamics, and when you're putting a central equation of output and index as perfusion, you want to reflect on whether it's the hemodynamics that are causing the output to be low, or is it a true myocardial problem. When you think about shock and hypoperfusion, the word subtly means it's a true myocardial problem, but you want to make sure that will decide on what you intervene on. Of course, cardiogenic shock, when you're talking about cardiogenic shock, you want to rule out all other shocks. I'm not going to go into the details, but simple things of mechanical problems and hypovolemic shock, old lady post-cab obstruction, outflow obstructions, these are all simple things you have to go through your differential before you presume this is true cardiogenic shock with a myocardial problem. And this is, I can share these slides if you want, but you also need to remember that you can have a combination of shock. Just because somebody has a low EF of 20% doesn't mean that they'll always have cardiogenic shock, but just because they have pneumonia doesn't mean that they'll always be in septic shock and not be in cardiogenic shock. And that's where your definition of hemodynamics perfusion is relevant, to have mixed picture and systematically treat either of them. How do you diagnose cardiogenic shock? Of course, there's no a diagnostic test. An EF of 10% doesn't mean you're in cardiogenic shock. An EF of 60% doesn't mean you're not in cardiogenic shock. The hemodynamic profiles are probably the most relevant aspect for us to define. How do you assess the hemodynamics, to be honest, is up to you. If you're a stellar echocardiographer and in the middle of the night you will get a cardiac output index by calculating stroke volume, CVP, SVR, so be it. I'm sure you can get an MRI in the middle of the night and do those things, but echo is feasible. If you want to do a Swan-Ganz catheter, that's fine. If you want to bet your kidney and do it on physical exam, so be it. But know that the decisions you're making are highly time sensitive and life saving or killing, that you want to be sure about your information. And that's where knowing the limitations of physical exam, data gathering are quite relevant. So when you look at the profiles which were defined by Lynn Stevenson initially, we all know the warm, dry, warm, wet, cold and dry, and cold and wet, right? A majority of the patients are actually in cardiogenic shock and are cold and wet. There is about 5% of patients who are cold and dry. They're not volume over breath. So it's important to recognize those. In general, for heart failure, a lot of them are warm and wet when you look at the population studies. Congestion and low perfusion, right? So congestion is volume in the lungs, volume in the legs, and that's just a chicken up there to see whether you guys catch it or not. No one had any reaction. And volume in the gut. The subtleties of volume, essentially, especially in the lungs, and I keep hearing this quite a bit, the patient is able to lay flat. I don't know what that means anymore, because patients come to the cath lab walking, lay flat, and it's 30. So if they're laying flat, it's okay, but I can't guarantee anything by just that assessment that they're laying flat and feeling okay. So be wary of the variations. Same thing with gut edema. Gut edema, you can have a lot of gut edema and not show up as ascites. Your venous system in your gut can hold on to a lot of volume. Perfusion assessment, cold and clammy, of course, you know that you guys are allowed to do a physical exam on patients. Right? It's not banned yet. So make sure you touch the patient. Perfusion in the legs is one. Two is the most peripheral aspects of the body. If you're laying flat, the kneecaps, sometimes it's the kneecaps that are cold, low perfusion state. For the rest of the body is actually not that cold, but your index is 1.6. I'm sure the heart failure fellows will agree. How many times have you seen an index of 1.5 and the guy is warm and perfused? Other thing is edema. Make sure you check for sacral edema. If you're laying in bed for a long time and you're coming in, your feet might be okay. And don't don't be nervous to push. Pitting edema, sometimes you just do a light touch. It's actually a lot of tight pitting edema, so you got to push into find out. So volume overload and hypoperfusion, but with the focus of hypoperfusion for cardiogenic shock. We talked about hemodynamics. Of course, there's something called as overutilization of Swan-Ganz catheter, which is relevant, but even for boards, there are class 1 to 2A indications for Swan-Ganz catheters per ACC. So if you guys go look at your guidelines, there are very classic defined indications to do the Swan-Ganz catheter, some which are vague but realistic, as simple as, I don't know what the volume status is. Right? The guy says he can lay flat, but his X-ray looks crappy completely. So you're doubting your assessment. So read through those indications, because that's essentially recommendations that you want to define hemodynamics. In the setting of cardiogenic shock, the way I look at it is, if the definition of cardiogenic shock is about cardiac output, then there's no better test than assessing cardiac output, apart from using a surrogate of a venous saturation in the central axis, which has some limitations. And as I said, if you can be sure about stroke volume and estimate a cardiac output from an echocardiogram, I'm fine. But you got to be sure that you need to use that to do interventions like inotropes and take the risk of VT. So in my mind, a Swan-Ganz is the least of an intervention when you're treating somebody in cardiogenic shock. These are the indications. I will let you guys, I go through the ACC guidelines, but really it's differentiating hemodynamic and permeability pulmonary edema or dyspnea we talked about, whether it's truly high wedge or not, differentiating cardiogenic and non-cardiogenic shock. And my personal philosophy is, if somebody's EF is 20-30% and they came in with pneumonia and they're on pressors, I don't know what they're in. They could have come in with septic shock, but now they could be in cardiogenic shock. So float a Swan. If a person has a low EF and is ending up on pressors, that's a bad sign. Define what you're doing so you can act on it. And of course, tamponade, perioperative management, these are all indications that are listed up there. Myocardial infarction and use of Swan-Ganz, as the comment I made on all the interventional blasts who's going to be in the cath lab. If someone comes in with STEMI, gone are those days where people are arguing whether you need a Swan or not. There's data that's out and coming out that hemodynamic tailored treatment of STEMI cardiogenic shock has better outcomes. It's not about the bad press for Swan-Ganz catheters has always been because of people need to know how to use it. How many people think art lines save lives? They don't save lives, it's what you use it for. It's an investigation. So using it in an MI setting has some specific indications, like management of cardiogenic shock with pharmacological and or mechanical therapy. You're recommended to put in a Swan-Ganz catheter. It's in the guidelines. So I'm going to skip these things, but define hemodynamics. And when it comes to once you've identified or suspected cardiogenic shock, the question is, how do you treat it? Right? We all know shock is bad. Inotropes, pressors are being phased out. Practically, people will end up on inotropes and pressors because there's a lag period of time, diagnosis, so end of the day you will be on some inotropes or pressors. But if you look at, this is an old slide, right, 99, it was recognized in 1999, that if you're on increasing doses, even one high dose inotrope, your mortality is 21%, that's inpatient mortality. And how many times have we seen patients get transferred over here on epi, nor-epi, vaso, dobutamine, right? So they're just dying actively. So there's a role for early mechanical support. On the other hand, of course, there's risk of mechanical support. So if you have a mixed venous of 50 and you use 2 of dobutamine and the index has gotten better, you can argue on maybe just holding off and seeing how you do. But You need to have that objective assessment that you're making a difference in their perfusion by the intervention that you're doing. Also remember, I personally don't like using inotropes empirically unless it's a dire necessity, because you're taking some risk of VT. So if someone's like lactate of 4 and dying, you can put them on dobutamine, but you have to ask yourself, why can't I do a balloon pump? Because it's Sunday and we want to sleep at home? Probably not the valid reason. So, because if you put somebody on inotropes, they're already fragile, they have a VTRS, you're done. So you're taking an unaccounted risk of dysrhythmias when you put people on inotropes. We do that regularly, but I personally would like to have an objective assessment of how bad the hemodynamics are, how bad the index is before you justify that risk. If somebody's index is 2 or 1.9, it's not that bad in the scheme of things unless you need somebody to be on inotropic support. Another thing is systemic vascular resistance, right? We talked about it. If somebody's systemic vascular resistance is 2000 with an index of 1.7, you probably shouldn't be putting them on inotropes. You could get away by doing afterload reduction. So you're taking undue risk of VT, so keep that in mind. The other aspect to remember is, and we'll talk about it in a little bit, when people come in shock, you need to think about, of course you need to think about now, today, tomorrow, but you also need to think about the next few weeks to months where these people will end up. And one of the destinations is VAD and transplants, right? So when you think about transplant, and when you think about VAD, a lot of people who come in cardiogenic shock, if they're profound, we probably might not be able to optimize them for a transplant. But if you look at VAD data, the INTERMAX definition, I'm presuming everybody knows the INTERMAX classification, right? It's class 1 to 7. One is people who are in profound cardiogenic shock and slipping down. If somebody gets a VAD at INTERMAX level 1, your immediate survival that you see is terrible, and that survival curve never comes back to normal all along. So bottom line, shock is not good, but if you're going to take people in shock and do a major surgery like VAD, they won't do well. So a lot of your interventions that you're trying to do with cardiogenic shock, if you think they'll end up needing organ replacement, you are trying to get them better to a different INTERMAX profile, which is relevant to improve their outcomes. And to some extent, actually, Barry did a study on our data which showed that if you take them from low MELD to from a high MELD to low MELD, MELD is a good predictor of outcomes. If someone comes in high MELD and we modulated them and make them low MELD before VAD, their outcomes were as good as somebody who came in with low MELD and stayed at low MELD. So by modulating their risk, you might be making a better impact. The number of patients who are coming in cardiogenic shock and getting an LVAD is actually coming down, which is a good sign, but I don't think we'll ever eliminate them, so people will show up in shock. Any questions till now before we go on to management?
So I assume that the INTERMAX 1 doing very poorly is an average of everything. So there's going to be a lot of people who have a lot of other organ dysfunction. But if you had the 40-year-old who's in INTERMAX 1 but was 2 weeks ago healthy and now he just has myocarditis, or giant cell myocarditis, does that mean that you should not vet?
Well, so you bring up a good question. That data is always retrospective. INTERMAX 1 people don't do as well as people who are INTERMAX 3. But I can't control people coming in cardiogenic shock. So whether you do a VAD or not is a different discussion. But in today's world with so much acute mechanical support, you can argue on not taking people in at a remaining INTERMAX 1 level. INTERMAX 1 level is like actively dying. So I don't think the question is don't do it, but be realistic in whether you can improve their state with the current support that you have. And for a health system standpoint, it's a recognition for all cardiologists that don't wait until they become INTERMAX 1. Start introducing the concept of VAD Intermax 2 for sure on inotropes, 3 for sure, 4 is maybe, until 4, 5 there's data that you could do a VAD on these individuals. So management of cardiogenic shock, of course, is complex. There's a lot of controversy, but this is just a paradigm in one of the articles. But you are treating pulmonary edema. Morphine is underutilized in heart failure. Nitroglycerin is underutilized in heart failure. I don't know whether, I've not seen it as much. The guy is gasping for air with a blood pressure of 160 over 100. A simple sublingual nitroglycerin will relieve pulmonary edema. So remember that in acute exacerbation of heart failure, if you're hypotensive, you're probably not going to do that. But as I said, you can have hypertensive state with high resistance. You could use nitroglycerin, morphine, which are good medications for acute edema in these individuals. You want to mediate hypoxia very early. Do not hesitate in electively intubating these patients. If somebody's blood pressure is 80s and they're huffing and puffing, just electively intubate. Don't try to drag it out and put them on, you can do BiPAP if you want, but optimize the oxygenation. I don't like hearing, SATs are 96% or 99%. That's what a lot of bedside nurses will tell you, but the guy is breathing 35, right? So he's breathing 35, so decrease the workload, always put him on oxygen. Of course, when somebody is in cardiogenic shock, the definition here is, use dobutamine, dopamine. There are a few trials, right? The DOPA study in cardiogenic shock, the pressor choice, end of the day, the concept is you should probably not use a bunch of pressors. Norepinephrine seems to have a signal that it works better when you talk about comparison of pressors. But in my mind, if you know the hemodynamics, don't treat the blood pressure. If somebody's blood pressure is low and they can't handle dobutamine, DOPA is a good temporary choice that we use to augment it until you are able to put in a mechanical support. If someone's hypotensive, milrinone is going to vasodilate them more, and milrinone takes a while to act, right? Milrinone takes about 6 hours to act, and we don't bolus people with milrinone anymore. When it first came out, we used to do it. It causes profound hypotension. So the immediate action medications, your choices are either dobutamine, dopamine, epi, or not epi for blood pressure. If you want inotropic support and you have blood pressure room, even in the 80s, 90s, you can do dobutamine. Sometimes, even if their blood pressure is in the 90s, I've used milrinone and gotten away, because if your milrinone augments the output more than dropping the resistance, you might get a blood pressure advantage. So it's a subtle balance whether you want to do that or not. Make sure you stop AC inhibitors, beta blockers, as simple as this sounds. Unfortunately, as much, there are times where you have people on dobutamine and metoprolol, right? So subtleties of these, make sure they're all DC'd if someone's in shock. And also you can tailor your medication. If someone's in shock and by mistake they got Coreg, you probably want to use a beta stimulant to counteract that at that stage when you're salvaging people. So again, when you look at the HFSA recommendations, the inotropes are out there. Based on evidence, dopamine seems to have a negative signal as much as we use it quite a bit. There are 2 studies that showed that norepi might have a better impact. It's tough to know. End of the day, you use what you have for blood pressure maintenance in the short term. So mechanical support. There's a plethora of devices that are available. Which pump, when and where is very dependent on the timing and accessibility. So knowing about each of the pumps and knowing the limitations of which you can get in the middle of the night is probably very relevant depending on where you guys end up practicing. Intra-aortic balloon pump, the tandem heart, IMPELLA, 2.5 and CP, and then of course peripheral ECMO. These are all percutaneous options. Surgical options are IMPELLA 5.0 needs a graft. I don't think you can put it in percutaneous yet. Of course, central ECMO, and then central, centrimac, and you can do a permutations of circuits in the chest, RA to SVC, whatever you want, but the concept is central ECMO means you're taking venous blood and then pumping into the arterial circulation. We'll talk about each one in a little bit. As I had mentioned before, cardiogenic shock is the beginning of a painful journey for the patient. It's painful for us also sometimes. You guys have seen patients here supported for months together, not knowing where to go, what to do. Some of these mechanical devices now have created some evil dragging out times because now the patients are doing better with axillary balloon pumps and walking around and they don't want to die. So these are all perspectives that are evolving, but what's important to remember is when you look at this is the 2017 consensus for the first time, a recommendation on how to organize shock. A lot of this is a STEMI focus. I want to bring that caveat. A lot of the work in shock has been on STEMI shock. Non-STEMI, non-MI cardiogenic shock has lacked literature and outcome. This year there have been a couple publications in from Virginia, and then I think another one came from Colorado on if you organize systems even for non-MI shock that it works about the same. The concept is simple, like the of you guys who've known E-Step, his famous words were, why are we having journal club at 2 in the morning? So if you have journal clubs like now and agree on a treatment plan and organize for shock, I think things will improve, because half of your battle in the middle of the night is trying to wake somebody up and get something. So the organization of shock has been the most important advancements in cardiogenic shock, apart from, of course, all the machines and devices. So think about where the patient is journeying. All the interventional blasts, you decide whether you have reperfused enough that the patient is going to be recovered and you think you're comfortable the patient will get out. Or if you know that it's been a week of an MI and you just opened it up and there's like TIMI-1 flow and you just feel better by looking at good pictures and the heart's gone, then you better think about what you're going to do moving forward. So that's where this recovery comes. And the difference in where you're heading also has an implication on what you're doing. There's, I don't know if you guys have kept track of the unload trial that was published in AHA on unloading the LV during an MI. So if you're promoting recovery, there's a push towards unloading the LV even before you revascularize. Also with the concept that after you revascularize, you want to rest the heart so you promote recovery and decrease the scar burden. So if you're going to give a recovery chance for somebody who's coming in MI, I think the strategy of supporting is a little different, even though the principles are the same. Same thing with myocarditis, you're expecting recovery, right? So knowing where you're heading is important. If you end up getting somebody who has chronic heart failure for 20 years and then in cardiogenic shock, unless you're going to do some magic, you know they're chronic heart failure. They failed medical therapy. You have to think about next steps already. And there have been times where luckily we had worked it out and we did not do an ECMO in people who were like PVD, amputated, not a candidate, and we made a decision that if we do something aggressive, we're not going to be able to get them to a durable VAD. And that's the important decision making as a team. Because you want to think about temporary MCS, but then what next? What are the problems that we have? What can we fix? What can be revascularized? Can I get them to recovery? Will I be able to get them to VAD? A lot of times you don't have an answer, but that's okay. But if you have an answer that you will not be able to do something, then that's important to consider at this stage. So you talk about palliation actively, and that's a integral balance between palliation and aggressive care. You don't want to go either extreme, right? It's easy to put everybody on palliative care sometimes, and it's easy to let people die. That's what we talk about on our service. At the same time, you want to give a balance of this final destination for VAD or transplant, but keep that big picture in mind. Always, in general, the monitoring of hemodynamics, monitoring of lactate, and monitoring of liver function, all these things are relevant for adequacy of interventions treating cardiogenic shock. Optimizing the milieu for the heart so that it performs the best, optimizing the milieu for all the other organs so they can recover either to recovery or to do a vado transplant because you want the organs to recover. And then of course identifying other complications which you don't expect, legs being cut off, perfusions, infections. So you can do a complex left main PCI and send the patient to the CCU and not look at retroperitoneal bleed, all your effort is gone, right. So these patients are sick enough that you want to anticipate all the other issues and catch them early on. And of course monitor the recovery for the heart if you're going to go for a recovery pattern. I categorize cardiogenic shock into 3 sections because those sections are important to organize care because there are multiple parties involved. Post-STEMI cardiogenic shock is probably the easiest to organize and the most data that you have. So whoever is going to be in the cath lab, wherever you guys go, if you don't have a cardiogenic shock team, I think that's the first thing to invest in. It's easy. You're the interventionalist. If you wear a heart failure heart, you don't need a heart failure specialist. You just need to define hemodynamics and partner with somebody who can monitor it if you want to go sleep after your PCI. But that's the easiest organized way. You are in the cath lab, put in a device, there's no debate on which device, which logistics, you put the most robust device that you can in the cath lab after STEMI. And that's where IMPELLA data has become compelling in a post-STEMI condition. The balloon pump has unnecessarily gotten bad press overall from data that's coming from a STEMI indication. So if you're in the cath lab and somebody's in cardiogenic shock and they need a mechanical support, you can argue if I put a balloon pump now and then turn around after 4 hours, it's not enough. Am I doing justice for the patient? I should just probably put in the best support if you're deciding on a support. On the other hand, of course, IMPELLA comes with a higher complication rate, so you have to justify that. But organizing care for shock in the cath lab is the easiest as long as you think about it and then decide on what to do, putting in a Swan-Ganz, putting in a mechanical support, making that decision and then moving on. Post-cardiotomy shock, which the surgeons deal with, but of course when they come out of the OR, they become our problem here, and depending on where you go, it might be your problem. So post-cardiotomy shock is a different breed, right? They've gotten some surgery, is it RV, LV, how to support, those logistics are different, you have anesthesia involved, so it's a different area for you to assess. Acute and chronic heart failure cardiogenic shock is of course a big chunk which is under-recognized is all of our patients who are in non-STEMI cases who come in slowly sliding. The problem with them is they're all over the place. They're on medicine service, they're in the ER, they're outpatient. So those organizing those care needs a higher vigilance. And even if you look at data out there, there's not much data on description of cardiogenic shock in non-MI heart failure cases on the database level. We talked about optimizing. This is Barry's paper. Barry was the last author on it, that we showed that if somebody has low meld and stays low meld, that's the blue line. Somebody comes with a high meld and we make them optimize to low meld, they actually do about the same, justifying the fact that intervening, because the discussion always comes, is there risk when they come sick with a high meld, maybe it doesn't matter what you do, they're already too sick. But that's not the case based on this data. So when you're supporting with the mechanical support, in general, or inotropes or pressors, right? We talk about blood pressure, lactic acid. In general, when you talk to a bunch of people, and maybe maybe if I ask you guys, you'll say the same thing on how do you assess somebody who's in cardiogenic shock. And I hear this a lot in the ICU saying, oh, he's making urine, lactic acid is okay, right? Blood pressure is okay, renal function is okay, mentation is okay, right? This is a common thing we talk about shock, right? Historically, entire cardiogenic shock literature and efforts have focused on these parameters, which are important, but all that is concerned about is the liver, the lung, the kidneys, the brain, but who's caring about the heart? The perceptions of goals to renal failure and everything is relevant, but because we've spent decades on that focus, people are not thinking about cardiac performance. That's why it's okay sometimes in an ICU setting that you see people putting patients on a bunch of epi, bunch of not-epi, because you're so focused on the output, renal output, you want to maintain perfusion, you're forgetting that the heart's struggling with your afterload. So the paradigm that's evolving is to be relevant in understanding not just the body, but how the heart's doing. The performance of the heart is one, which is cardiac output, LV-EDP as a preload, the blood pressure affects the performance of the heart. And same thing with cardiac load, right? You want to know how much load is on the heart because as you are treating the body with cardiogenic shock, you want to give the heart the best optimized state to work with you along with the cardiac support that you have, because nothing is 100%. So you have to keep in mind the myocardial energetics for you as you're treating the heart and not just douse with a bunch of pressors. And I'm sure you're not disappointed that I'm showing PV loops, right? The guys who know me from before. There's a whole separate discussion on pressure volume loops we can have, but this, everybody knows what a PV loop is, right? All fellows, right? Basic physiology of the heart is studied with a single beat. They're all good for boards, but they've fallen out of favor for clinical practice until recently that with this app and a platform that measures pressure volume loops, which we have, there's a clinical relevance that's resurfacing. But this clearly shows you this is the right ventricular PV loop and this is the left ventricular PV loop. The RV is a completely different animal. The way it behaves, the way it acts, the way it responds, we talk about it. But the fact that you have somebody who's come in with LV failure doesn't make them immune to have RV failure once you start mucking around. So if something's not working the way it is, make sure you recognize and pay attention to the other ventricle. Because you have an LV support and the guy is, you put in a CP and the guy comes out and he's still hypotensive, you got to ask yourself what the heck's happening. Sometimes you're in RV failure. So keep that in mind to optimize the other ventricle when you're supporting it. Same thing with RVMI. If somebody comes in with an RVMI and you put them on dobutamine, it could be a large circ and your LV could have been bad from before. So make sure you assess the other ventricle appropriately. We talked about cardiogenic shock. Don't hate the swan. And these are all the controversial studies. But I want to point out before we get into the MCS that this data is old, it's actually emerging, but there is data right now to show that if you do hemodynamic monitoring in the setting of shock, acute MI, versus don't have hemodynamic monitoring, you do make a difference in treating them. Of course, this is in an organized setting of training people how to use the information. So it doesn't work if you just put a swan and expect everybody to take care of things. Balloon pump. Balloon pump is a staple at our institution. I think there's a huge role for a balloon pump. It's very easy to put it in. Bedside balloon pump is quite easy. So if someone is in shock, putting in a balloon pump is the first thing that we have done. Even if somebody does, I think, needs an IMPELLA, and I know it'll take an hour for the cath lab to come, I put in a balloon pump. Because you have some mechanical support. By the time you move them up, you can use the same access if you want, unless you're completely stable. So use that judgment. If you're in the middle of the night at 1 o'clock and you're activating the cath lab and the guy's tenuous, it's not going to hurt putting in a bedside balloon pump and use the same access to upgrade. Sometimes you put the balloon pump and things turn around. How does the balloon work? Most of you know, but for the first year fellows, presuming you don't, because this is cardiology. Two main mechanisms is by unloading the LV and then by perfusing the coronaries. So instead of going into inflation, deflation, systole, diastole, the way I look at it is it's a simple equation. This is the heart, this is the balloon, and both are going together. What that means is if this is the heart, in diastole, the balloon is inflating. So in diastole, if the balloon inflates, the blood's going to go back and perfuse the coronaries. In systole, the balloon is deflating. So when the blood comes out, the deflation is providing suction for forward movement. So just remember that both are going in the same way, and then figure out in your brain systole, diastole, unloading versus perfusion. It sits, typically it's put in the groin. It sits from the arch right after the subclavian. On the X-ray, you can aim for the bifurcation of the trachea, and then you want the balloon to sit here above the renal artery so you don't impede the perfusion of the kidneys. That's your X-ray. That's the balloon pump tip. This is your bifurcation of the aorta. And we talked about the mechanism. And then when we put it in the axillary position, the balloon pump is, all of you guys have seen this, but it's just the same balloon going in a reversed way. And the positioning is about the same, except the marker looks different. But when the balloon pump is devised to go through the groin, so the marker up here is technically the distal marker is more prominent. So if you put it from the groin, you'll find this marker much more prominent because that's what they made it for. But when you put it from the arm, that marker is actually below. So the marker you're looking at up here is not that prominent compared to what you would find from the groin. But it's the same position. But the axillary balloon pumps comes with their own nuances, especially the new fellows. If you're not used to it, don't muck around with it. Call us for adjustments, pushing in or moving it around. It comes with a lot of its own nuances. The other percutaneous pumps that we'll talk about is IMPELLA, tandem, and peripheral ECMO. So this is 2.5. In my mind, for cardiogenic shock, 2.5 is no better than a balloon pump. I wouldn't waste my time putting in a 2.5 IMPELLA for cardiogenic shock. You can do a high-risk PCI and take it out, but if you're going to use an IMPELLA for cardiogenic shock, it makes sense to either do CP, acknowledging that it has its own problems with hemolysis, or go to the 5.0. And if someone comes in with the 2.5, you kind of take it, but primarily I wouldn't do that unless you have no other choice. But if you notice, the tandem heart can go up to 4.5 liters per minute. Of course, peripheral ECMO can go up to 5 liters. The duration of support is kind of meaningless because none of these, I'm sure you guys have not seen somebody get off the balloon pump in 6 hours. All these are going into months for us, but that's the FDA approval part. Tandem heart, essentially the concept is you have a cannula transeptally put into the left atrium. The blood is being sucked, that is oxygenated blood is being sucked out of the left atrium, and then if you look at the cartoon here, this pump is sitting outside. This is sucking blood out from the venous system, from the left atrium, and then pumping it back into the iliac to the arterial system. So it's oxygenated blood, which means that your lungs should not have any problem. If you're having a lung problem with oxygenation, then you can't use a tandem. It's only circulatory support, not oxygenation support. That's the example of a tandem monitor. You can see on this echo image, you see that cannula up here that's going transeptal right here. And you can go up to 4.3 liters, and as you increase the flow, your wedge comes down, and it's unloading the left atrium essentially. The IMPELLA devices, we talked about 2.5, CP, and 5.0. All of them have a similar concept. They sit across the aortic valve, and they are essentially sucking blood through this rotor from the LV outflow and pushing it out into the aorta. So it's a trans-aortic pump. Most of it goes from the groin, the 5.0, typically we're doing from the axillary artery. Hemodynamic benefit for an IMPELLA, if you look at the reason why the IMPELLA gets a better press is it unloads the heart. So if you look at this, let me go back and orient you guys. So this is a normal pressure volume loop, right? The basics are this is pressure, this is volume. This line defines contractility. This line defines diastolic property without going into the names and details. When this line goes down, your contractility has changed. No matter where the PV loop sits, if your line doesn't change, then your contractility has not changed. What that means is I can make this PV loop look like this, but if I keep it in the same line, it's a hemodynamic impact, not a myocardial problem. But here, if you look at it, the contractility has dropped. So this red line represents a cardiogenic or a heart failure state, acute heart failure state. Your LV EDP has increased. Pressure has gone right from about 16, 17 to up to 25. So when if you put in an Impella, of course you unload, so the pressure comes down. But what's also remarkable when you unload a heart is that your shape of the PV loop becomes triangular, which is conservation of energy. So if you actually put in a 5.0 Impella and increase the speed, you can move this all over back here. So the energetics of the heart improves, and that's why unloading is preferred in a setting of an MI, because you're decreasing the energetic consumption of the left ventricle. And so all the trials, I'm going to skip them, but the message for the trials is don't listen to Impella guys that balloons don't work, because that is in the setting of all the trials. Or an acute MI setting, if you put in an Impella versus a balloon, I think balloon pumps have not shown big benefit, but there's also another trial where Impellas failed to show benefit. So beware of that evidence and not extrapolate to everywhere. 5.0 Impella is what we're doing quite a bit. This is one of our patients. I'm sure you'll see this is the Impella sitting here with the graft. Our surgeons put it in. Essentially, it sits in the similar position. This is tightened up. That's another thing for Impella. If you guys are managing it, or if you put it in the cath lab, make sure it's tightened properly, because more often than not they fall out because this particular cap is not tightened. Impella monitor flow, you guys have seen it, but it can range from P2 to P8. I would not go lower than P4 when you're maintaining flow. P8, P7, P6, you can leave them. If you're trying to wean them, maybe 5 minutes at P4 is the lowest I would go. Beyond that, I wouldn't leave them at a lower level, because you're going to clog the pump. Aortic valve opening and contractility is an important concept to remember in any of these continuous flow devices, especially ECMOs or even tandem. So this can happen even in a VAD, right? This is a patient, you have a flat line art line, no pulsatility, and a map of 84. If I show this picture, you'll probably say this is an LVAD patient, right? It's probably fair. But this can happen even in a tandem. This can happen even in an Impella. Impella technically is a continuous flow pump. So I also hear this sometimes saying the patient has an Impella, oh, he's lost pulsatility, and then we're trying to code the guy. Right? So remember that you don't have to have pulsatility for an Impella as long as you maintain perfusion. If you have pulsatility, that's okay, but if you don't have pulsatility, the guy is not dead. Maintain perfusion with a continuous flow even in an Impella and a tandem. This was in fact a tandem patient who we then added milrinone, and then you see intermittent pulsatility and the relevance and importance of maintaining aortic valve open. Now the Impella is different because it is transaortic. So in those patients, I actually don't care whether you maintain pulsatility or not. In tandem and ECMO, because it's not unloading it directly from the aortic valve, if you don't maintain pulsatility, it means the aortic valve is not opening, which means you're promoting some stagnation in the heart, which is the most relevant in ECMO. And for many years, even now, people debate about it. But when you put in a peripheral ECMO, sometimes it can happen even in central ECMO, you're essentially drawing blood from the right atrium, taking it out, putting it into an oxygenator and a pump, and then pumping it back into the iliac artery, right? So it's a heart-lung machine. When you use an ECMO, as much as you get very good perfusion pressure, if you put somebody on an ECMO, you're having You can have a continuous flow perfusion pressure of 80, 90 and you're happy the body is doing okay, except that when you look at the pressure volume loop, actually this is a reflection of it, that loop becomes narrow and then moves to the right. Can anybody tell me what that means? Yeah? Extremely high afterload. So, as much as over here the blood pressure is up to 100, you could walk away from this patient saying, I did a great job, pat yourself and say the perfusion pressure is 100. But look at the LV. LV EDP has gone up and essentially the energetics here, the MVO2 consumption has gone up to 24. So, if you leave a heart like this without pulsatility, the load on the heart is extremely high because you are having an iliac cannula pushing blood at 100 millimeters mercury, while a crappy heart that you tried to save is barely able to pump against it. So, I have seen a heart completely clot off. If your aortic valve closes and the heart's barely able to move, over a period of time slowly blood trickles into it and the whole heart can clot off completely. So, always keep in mind when you put in a peripheral ECMO, sometimes even for central ECMO, because if you have an aortic cannula and a central ECMO, you can still put the pressure on the LV. When that happens, make sure you assess aortic valve opening. Now, some people recommend an IMPELLA for every patient who goes on an ECMO to put an IMPELLA in. I'm not sure we are completely supportive of that, but you want to do something to unload it. This is a classic example of one of our patients on peripheral ECMO. You see how there's pulsatility, but then you lose it occasionally. But for the most part, there's pulsatility, except that the lungs are flooded, which means you're suspecting that the wedge is going up, you're not unloading, and then these are the patients that you want to either add inotropes or put a balloon pump or do something to unload it. So, we talked about IMPELLA versus an ECMO plus balloon pump. This is an example of a patient. Look at all this sludge. This is a patient with a central ECMO. Look at all this. And this is a patient who had come from an outside hospital after 2 days and open chest. They take him into the OR, and then aortic valve is barely opening here, right? And then they put the patient on milrinone, and now all the sludge and the clots are gone, but they went somewhere. This guy in fact had a big stroke and died neurologically. So, your neurological outcomes can get affected by these things. Monitoring hemodynamics. Can you guys recognize his head? Anybody? Who's this? Huh? Masood, yeah. So, the director of the ICU is getting down there, down and dirty and doing hemodynamics. So, nobody has an excuse not to do it. So, when you have a Swan-Ganz catheter, don't see the patient if you're not going to collect accurate hemodynamics and talk about them. Remember that, because you're doing injustice to the patient by leaving a Swan and not using the information. So, level it, do the right accurate information. Inaccuracies are extremely possible in Swan-Ganz. What is the problem here? Only fellows. Heart failure fellows. What is the problem in these hemodynamics? Huh? PA tracing. That's right. Where your CVP is 18, but that's an RV tracing. And I have seen people put on Lasix drip, CVVH, and do all these things, even here. So, wrong information, right? I say garbage in, garbage out. You might be the smartest kid on this planet, but if you put garbage information in your brain, you're going to make garbage decisions. So, always be sure about the hemodynamics you're getting, leveling, zeroing, and the tracing is extremely important. Don't just read the number. The other part I want to point out is the cardiac output and index and SVO2, right? So, when you look at the monitor, actually the new monitors are a little different. This is an old monitor. The new monitor has a bunch of outputs on it, and then there's a venous sat. But in concept, that's no different than this. There's a 2 outputs over there. One is instantaneous and one is average. But either ways, the output calculated here is being calculated with what technique? The number that is showing up here as 6.2. Fic. How many fics? So what is, so if you do 82 is coming from where? 82 is, what is 82? It's SVO2, right? How is it being measured? No, you do have to calculate. What is the technology though, right? You have a sensor at the tip of the swan, which is an infrared. When you guys implant it, if you actually calibrate it, there's a light that comes on at the tip. There's an infrared tip which measures your SVO2. So the answer is wrong. It's not FIC. This you use to measure, calculate FIC, but it is not. This is not being calculated from this number. This is a thermodilution with a heating coil. So when you put in the swan catheter, there's a heating coil. That's why you have this extra port. So it's important to recognize that because these two numbers might not match up, and that explains. So your mixed SVO2 will be 95, but your cardiac output here will be 1.2. Which one are you going to trust? One, does that make sense? So it doesn't make sense. It makes sense that it is disparate because both are not coming from the same technique, which is important to recognize because that gets missed a lot. I've had people go on tons of mildrenone with an index of 1.2 and then on epi and their legs are all falling off because of pressors, but the mixed venous is 95. So both are different. If both are disparate, you would trust the FIC provided you validate it with calibration. Okay? These are all bunch of calculations, right? No hemodynamics are complete without these calculations. So don't see a patient and come out and say CVP of 5, PA or something output. A third-year med student can do that. You want to complete the hemodynamics, you need transpulmonary gradient, PVR, maybe you don't need cardiac power output. And diastolic pressure gradient, you should at least have TPG, PVR, and stroke SVR. The rest of the equations are extremely important. In fact, all the heart failure fellows should know how to calculate RV stroke work index, PAPI, and then the cardiac power output. I can share this with you guys to know this, have a template and calculate for all the patients. And I think we're 5 minutes over, but the reason why these are important are if you don't calculate systemic vascular resistance, you're going to miss this patient whose resistance is high on this pressure volume loop where your index and output are going to be not very good. It's 2.06, output of 2.06 with a high SVR, and if you start putting these patients on dobutamine and mildrenone, you're not treating the systemic vascular resistance. So if you don't know the resistance, how the heck are you going to treat it? Same thing with low SVR. If somebody has a SVR of 600 and an index of 3, why are you on dobutamine and mildrenone? Right? You wean off the dobutamine, treat the hemodynamics, and if you don't know the hemodynamics, you're not going to treat them properly. Preload is another thing. Classic example, post-acute MI, you put in a balloon pump, people come to the ICU, no Swan-Ganz catheter, they're hypotensive, their CVP might be 0. You're putting them on a bunch of inotropes because if your preload is low, all you got to do is give them volume. If your CVP goes from 2 to 10, your hemodynamics improve. Right? I think I'm going to stop after this last slide probably. Yeah, I think that's probably. It's very important to recognize pulmonary hypotension. You're tuned to walk away from a blood pressure of 120 over 80, or even if a systemic blood pressure is 160 over 100, you're not panicking. You know you can treat it, right? But then if a PA pressure is 90 over 60, everybody's freaking out. If your systolic is 60 over 40, you're freaking out But if your PA pressure is 20/12 with a CVP of 20, you're not freaking out. That's how you're trained, and that's how a lot of ICU guys are trained. But systemic hypotension is no different than pulmonary hypotension. The difference is if somebody's blood pressure is 60/12, they feel like crap. Their wedge is probably 30 and they're short of breath, and it's obvious in your face. If somebody's CVP is 20, their liver is not crying at you. So it's not obvious in your face. So you have to pay some extra attention in picking up RV hypotension, which means that if somebody's PA is 20/12, and high CVP, it's equal to having a high wedge and short of breath, and recognizing the consequences of high CVP by either measurement or abnormal LFTs. Right? Otherwise, you'll miss a bad RV. And the transpulmonary gradient is extremely important, especially post-transplant and post-VAD. If you don't have a wedge, you're not doing the right thing. Because if you look at this example, your PA mean is 40/20 with a mean of 27. If you don't do the wedge here and you presume the wedge is 20 because your PA diastolic is good, then you don't know if the wedge is 2. Because here your transpulmonary gradient is only 7, you don't have to worry about resistance. But if your wedge is 2 and your transpulmonary gradient is 25 with the same PA pressures, that RV is going to die. So in this situation, I would empirically start patients on Revasio, Milrinone, whichever it is, post-VAD and post-transplant, because you want to protect that RV. So if you don't have a wedge, you're not going to get the accurate measurement. Now, if you have wedged already a few times and you want to slack a day because the wedge and PA diastolic correlated, that's a different story. But make sure you get the transpulmonary gradient and resistance calculated. I'm going to stop up here. There's some weaning stuff, but I think it's important to have a close monitoring of these shock patients, timely identification, timely intervention, and close follow-up. You can put in a device, but if you don't follow whether that device is working or not, it's not good. And in fact, even in our services, we've missed the boat sometimes. You put a groin balloon pump and the mixed venous is 36 for like 5 days. Right? You have to question saying, is 36 compatible? Why are we dragging it out? So be mindful that know your goals, and if the mechanical support is not working, you want to augment the mechanical support early on and not wait until later. All right, thanks. Questions, comments? Yes.